All right, folks, it's Healthcare Unfiltered, and I have a dear friend and a colleague from long time ago joining the show. And Anand, you've made it. If you're on Healthcare Unfiltered, that's it. I mean, it's downhill from here, my friend.
Yeah, I'm so happy to be here and reconnecting with you after so many years. For everybody that doesn't know, Dr. Navan was one of my early mentors as I was a young physician in training at
We're
like
still
right.
young. We're still young. That's the
Yeah,
topic of today's
exactly.
podcast. Remember, we're not going to age, but I reached out to Anand. We'll do some formal intro because I've been really very impressed and intrigued in what you're doing over the past couple of years, specifically not just concierge medicine, which I want to talk about, but also your focus on preventive health and things of that nature. And I think the topic is really of interest to our viewers and listeners. It doesn't talked about much, and I like your approach, although I have some questions about it that I would like to really better understand. So why don't we start just telling people who you are, and your training and what you do currently?
Sure, absolutely. So, my name's Anand Patel, as Dr. Navan mentioned, and given my last name, my parents said I only have a few options for a career, and so being a physician was kind of imparted upon me early
Pretty
on. And
much.
yeah, I went through the typical training and then did medical school in the Chicagoland area, ended up working at Lutheran General with Dr. Naban early in my career, did internal medicine, had small aspirations of becoming an oncologist like yourself for a period of time. And
I
then
really wanted you to be an oncologist, if you remember those days.
I do. And then I actually ended up working as a hospitalist at the place that I trained at Lutheran General for almost a decade. During that time, being a hospitalist, it gives you the ability to work a week on and a week off. So on my weeks off, I was able to explore a lot of different opportunities, being a physician, but also having an entrepreneurial background to do other things. So I worked with the pharmaceutical companies as a subject matter expert and speaker. I worked as a medical legal expert. I started and sold a brick and mortar physical therapy business. So I've kind of dabbled in a whole bunch of different things. But really after COVID, I got to a point in my career where I was like, it wasn't really giving me the energy and joy that I wanted, and yeah, after COVID, I think everyone was stuck in their homes, drinking a bit more than they were used to, and maybe doing things and doing less things than they were for their health. And so I took a real step back and said, this isn't the way that I want to be kind of an example for my kids. And I wanted to get much more serious about my health. And like many things, when you go on your own personal journey, it kind of resonates with people. And as I started to make these changes, I started to talk to a few people and I got, a couple of my first patients, if you will. Really, it was kind of an informal thing where I was kind of doing more of health coaching and helping them understand how to eat better, exercise, prioritize sleep. And, that was something that really resonated with me and I really enjoyed it. I started taking a deeper dive and following the likes of Peter Attia, some of Mark Hyman's work, and some of these other people that kind of are in this longevity space, if you will, and really started to hone in on what I thought was important for me in medicine, where I could, really meld things that have been present for thousands of years, right? Like, why does heat exposure therapy work in saunas? Why does cold exposure therapy work? What's the importance of yoga and meditation and breath work? But also, how do I use AI assisted heart scans to make sure you don't die of a heart attack? Because I think there's utility in both things. And that was kind of the ultimate premise of how I wanted to practice was really utilize stuff that we know and pair that with the newest technologies and give people not just numbers at the end of their life so that they can say I lived to 100, but I always start my conversations with my patients and say, what's your perfect Tuesday at the age of 80? Right? Like you want to be skiing with your grandkids in your home in Vail. All right, well, you're 50. So let's work backwards. If your VO2 max is 22 right now, you're not gonna be able to walk to the ski lift. So we need to work. And, this is just like your 401k. If you want X amount of dollars of disposable income when you retire, well, you better start making those investments now. So that is really the way that I kind of frame everything for my patients. Everyone has different goals. So I have to meet them where they're at in their health journey and then really craft a plan that's tailored to how they want to get there. And obviously the way that we get there is kind of, dependent on each patient, but that's really what drives my practice and philosophy.
So was there a reason like you shifted? So you're a hospitalist and you're doing, the hospitalist work and taking care of patients in the inpatient hospital. Was there an event, a reason that made you decide, was it boredom? I mean, you just want to do something different? Was there something that happened that made you decide I'm going to do something different?
Yeah. Unfortunately, medicine has changed, and even in the short tenure that I was going through, kind of like my training and career at the hospital, a lot of the joy and autonomy that was there, earlier in like the 80s, 90s of practicing medicine was taken over. And, it became an administrative thing where everything was about the bottom line. And, physicians were kind of just not really regarded as they once were within this entire ecosystem. And I'm like, I don't know that this is the right thing for me. And, it's not really the type of work environment that I wanted. I wasn't really getting if you're a hospitalist and you see patients over, it's never a good thing. It's always the recurrent alcoholics or the people that have heart failure that are coming back, or unfortunately, a lot of people that are just kind of in their last cycles of life where they're kind of going to the hospital with, terminal illnesses. And we're really kind of just appropriating social work care for them to make sure that they can get what they need at those last stages. But none of these things were really aligned with what I thought was the best way to impart my skill set for these patients, right? And it wasn't something I would never leave work feeling gratified. And I think that big gap in going to work and not really getting and extracting out of it what I wanted, I didn't see myself doing that for the next few
Yeah.
decades.
Yeah, and you're not alone. I think a lot of people really complain about the administrative burden, and that, I've yet to meet really a physician that complains about seeing patients and caring for patients. Usually what they really complain about is the administrative and the autonomy. So, are you currently doing concierge medicine? Like, is that like, do I put you in the category of concierge medicine? Because I would love to understand more what concierge medicine means.
Yeah.
But I don't want to label what you're doing as concierge medicine if it's incorrect.
Yeah, and I think, I don't know that there's a good label, right? Because we're kind of like blazing this path as we speak about it. I mean, I tell everybody, so, if you come to Elevate Health, I'm like, you have to maintain your primary care provider, right? Because what I do is I say, the healthcare system is ran by two major entities, the federal government and third-party payers, right? So the federal government, we know, does a fantastic job at everything they do and everything's perfect, right? Like they suck. And
For
like,
those who are listening, I hope you
yeah.
understand. This is Dr. Patel being sarcastic.
Yeah, exactly. I mean, like they don't do things very efficiently or well. And then the other entities are, for-profit companies that need to answer to their shareholders. So then it's like, okay, these are the people constructing how your health should be. So when you go, you don't just, you go on vacation, you don't find the cheapest and easiest solution. You find the thing that aligns with what you, the experience that you want out of this event, right? And so your health should be just as important. The more that you invest into your health, the more that you should be able to get out of it. And I'm the conduit for that. You want to call me a concierge doctor, longevity doctor, whatever it is. I'm the guy that's going to keep you as healthy as long as possible,
So
right?
what's a longevity doctor, though? You mentioned this word twice right now. You mentioned earlier on, you mentioned like, you followed and read some of the work of these folks who are interested in longevity, and you mentioned longevity doctor. What is a longevity doctor?
I think it's a physician, like stating is somebody that really focuses on health span more than anything, right? How many healthy, functional years can I add to your life, right? We think about something like the Framingham risk calculator. That's 10 years. Well, it's okay if I don't have a heart attack for the next 10 years. I don't have a heart attack for 30 years. So where's my 30-year risk calculator, right? Like everything, we have kind of like a 5-year survival rate. Like, I get cancer is a whole different ballgame, but like the
So,
idea.
so, 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 so I don't want to put words in your mouth. It's not necessarily increasing your age. It's increasing the number of healthy years within your age.
Exactly. And like we refer that as health span as opposed to lifespan, right? And so it's really the maximal output of your health span. And so, yes, a lot of what I do would relate to primary care type duties. But then it's also like I'm also your exercise physiologist, your nutritionist, your sleep coach, and then your therapist at the same time, because you can't tell me that stress doesn't play an important role in this. You can't tell me food and, exercise and sleep and all these things aren't massive parts of your health, right? Because we have somehow constructed the idea that you seeing your primary care doctor once a year is the definition of health, right? Like, okay, my interaction with the healthcare system should be I see my doctor once a year. He doesn't give me any pills. I'm healthy. You're like, well, that's the stupidest way of looking at this. It's like, if you want to assess your health, it's the most dynamic thing we have. Every hour, your health is changing, right? So if we don't, I talk to my patients every 2 to 3 weeks. I'm like, hey, man, you said you were going to hit 15,000 steps a day this last week, and I'm looking and you barely got 10. What's going on? He's like, yeah, I sprained my ankle. I'm like, all right, well, let's address that. I didn't want 6 months to elapse before you're like, oh, yeah, I didn't do it because of this. we have to stay on top of it. We have to stay accountable. And that's really the beauty of this transition now, right? Thanks to all these advancements in technology, both between our ability to access patients in terms of where they're at with communication, but also with their health tracking and wearable data, right? Now I know there's a dashboard that goes on. You can't hide from me. I'm going to find you and say, hey, look, this thing that you're wearing told me that something's going on. I'm like, why is your HRV tanking? Why is your resting heart rate looking so bad? Are you stressed out? Like, so we have these insights that we can then work to address things before they start, right? Like you understand more than most that if I got somebody's CBC every 6 months for 10 years, that deviation from 4.4 to 13.2 in the white blood cell count normally wouldn't be that concerning. But like you've seen it over long, and now that you have data that is compiled over time, you get a much more clear picture. And we're not passing the buck off to 20 different people to try and figure this out. There's this centralized person that's monitoring this, right? And as we develop these tools, right, what we're developing in our company is independent LLMs that will scrape your data that will then personalize these outputs so that everybody, like, not only is it you and I watching these numbers, but then there's this third party above us that's like scraping things constantly. Every time we have a conversation, that gets pumped back into your record, and it's like, hey, you said that you were going to talk about checking their vitamins, but you never, sent the test out. So then we get that reminder. So your data gets uploaded to the LLM, and then it'll like pull out any irregularities or things that we need to assess. So it's really just this constant audit trail of your health to make sure that we don't miss anything. And I think
Okay.
that's a huge part.
So let's back up just a little bit. So my understanding, so just to summarize, what seems to me longevity is it's more like a healthcare maintenance type of thing, like maintaining your health and improving in your current health. So at least the health span is longer. So with that, if I come to you and I say I want to improve my health span, what do you do for me? Like what type of tests or things that you do, and how do you track my data once you do these tests?
Yeah, no, it's a great question. I think, right, there's two things. There's daily habits, right? Those are the fundamental things. And then there's the icebergs, like the cancers and the heart attacks and all that stuff. So the first thing we do is actually assess where you are in your health journey, right? You go to your doctor, they weigh you on a scale. Well, that's a really stupid measurement, right? Like it's like BMI. Who cares? Like I don't know what your body composition, like I don't know what your total fat percentage is. I don't know how much visceral fat you're carrying. I don't know what your lean muscle mass is. I don't know what your bone mineral density is, but I get one DEXA body composition scan, I get all those numbers. If I get those numbers in addition to your resting metabolic rate, well, okay, well, not you, but somebody, a healthier version of you could have a lot of visceral fat around their gut, right? And so that would say
Oh,
to
I
me,
have my visceral fat, don't worry.
so then I would say, okay, look, looking at that, looking at where your resting metabolic rate is, looking at your hemoglobin A1C of 5.6, this is the most important thing we need to attack. So for the next 3 to 4 months, our goal is going to be to reduce your visceral fat. The way you eat, the way you exercise, the way that you sleep, everything is going to be around this goal. And so, all right, we are going to get you set up. And what I've learned through this whole period is if I tell you 1,000 things to do day one, it becomes very difficult. But we get your blood work, we get your DEXA body composition scan, we get your VO2 max, we get your resting metabolic rate, and that
What's a
gives us,
VO2 max for those who are listening?
yeah, so a VO2 max is the amount of oxygen that you can maximally exchange with your lungs. And that is actually the best predictor of longevity and your health span out of all the metrics we have. So if there's anything ever to test, get a VO2 max, because if you see where you rank according to other people in your age decade, and if you are not in the top, quartiles, you are just, your risk of morbidity is about 4 to 7x than those people at the higher tiers. But basically, this is your ability to just do daily activities of daily living. So if you don't have a certain threshold, like if you start going under a VO2 max of 20, walking up steps becomes difficult. But there's a progression down as we age. So if you know that your VO2 max is 40 when you're 60, then you have a good chance of being at a place where you can still be functional at the age of 80. But if you're 40 at the age of 35, we got some work to do because we need to crank that up as high as possible.
And how
But
do you improve that? Just out of curiosity.
so There's lots of different methodologies, but there's something called zone 2 training, and not zone 2 by your heart rate, but zone 2 by the amount of lactic acid that's built in your blood, because that's the point at which we switch from aerobic to anaerobic respiration. So there's a point at which your lactate is constantly cleared out from your blood. Now, if you train at that level for consistent periods, so like for me, it's like walking on a treadmill at a 6-degree incline at a 3.4 pace, but you have to do that for 60 to 90 minutes at a time. And then you start to actually change the receptors on your mitochondria and things like that. So then you become more aerobically efficient. So as you do that, you increase your aerobic base. And then if you do that for 3 to 4 months, then you start layering in like high intensity interval training. So it's that kind of stepwise structure that we've seen the best improvements in patients' VO2 max. And obviously that changes from patients to patients relative to their training age. But that's my initial, set of testing that I get for all of my patients. Then I can say, okay, look, this is kind of where you're at physically. This is what your
You do
body.
a chest X-ray, for example, an EKG?
No, none of those. Like, so those things are kind of second tier tests. So it's like, a lot of these things, it's like, like you get an AKG on a guy that's 42 years old and he's like, I feel fine. He's been in sinus rhythm his whole life. What am I going to do? Say, see some mild LVH, right? Like, but that's not going to change my thing. It's like, if I want anything, we'll get an ultrasound of your heart, right? Some of these things, right? Like I get all of my patients, I get a lot of them that go, I went to the Mayo exec program. I like went to the Mayo executive health program. Like, that's great. What did they do? Like, oh, they did an EKG and then they did this. I'm like, okay, now what? Like, I don't know. I'm like, yeah, so what's the point of all this, right? Like, it's because they get to slap the Mayo label on there. And like, oh, I felt great. I went to the Mayo Clinic, right? And
But
yes,
isn't what you're doing also an executive physical and health? You just have a different philosophy which test to do. I mean, aren't you doing the same?
well, no, because but that's the whole point. Like the distinction between the testing and the follow-up on the testing is the whole thing, right? Because it's like if you got an ultrasound of your heart, and then you proceeded to drink like 14 units of alcohol a week thereafter, like that doesn't like it doesn't do anything, right? Like just saying that you're kind of okay now without a plan of how to improve. Does anyone have perfect health? No, there's always room for improvement, right? So the idea of the executive physical is to take that data and make it actionable, right? So it's like not only is it important on which test to ascribe to, but it's also more important, right? Like because if you think about heart health is such an important one, and it's the hill that I will die on, because the way that we assess heart disease in this country is so backwards, right? Because we go get an ancillary measurement like cholesterol, and like the basic cholesterol panel is ridiculous. It doesn't give us any insight, right? So now what do? Then we can add on things like apolipoprotein B, LP little a, right? LP little a is a genetic mutation, affects 20% of the populace. And if you have that, a much higher propensity for the development of heart disease. You can get lipoprotein fractionation. You give the analogy of if you have a crack in a sidewalk, and if you threw a basketball at it, it would not get stuck in this crack. But if I had a handful of tiny pebbles and I threw that at the crack, well, those pebbles could get stuck in that crack. And so those little tiny particles are your LDL particles, right? And you need to know if you do lipoprotein fractionation, you will know the size of those LDL particles and the quantity. So now you know how big the pebbles in your hand are and how small they are. The smaller they are and the higher the number, the increased risk you have. So there's all these levels of our ability to get much deeper in understanding what your true risk profile is.
Okay,
But all that is kind
let's
of,
go. But let's go back. What test you're gonna do? You're gonna do the VO2 max. You're gonna do the
yeah.
blood work. Take me through. I come to you today. We sit together. You order certain tests. I want to know what these are.
Yep. So then, like I said, the VO2 max, RMR, DEXA scan. Then the blood work, right? It's the things that you would normally see at your physician's office, plus those advanced lipid panel testing, plus we get more inflammatory markers, plus we get all your hormones, right? Because hormones are another big thing that everyone discusses in medicine because there's the traditional way of looking at it and the new way of looking at it. But that's kind of our basic cadre of tests, right? And then based on where you are, that's just like to get you through the door. And then after we decide what your risk factors are. Then we start asking other questions like, how deep do you want to go? Because all these other tests cost money. It's not like there's somebody picking up these tabs. And so we have to say, all right, is a Grail blood biopsy test or a Pronuva MRI scan or a clearly AI assisted CCTA useful for you? Well, yeah, you had 6 first-degree relatives with cancer. Like we definitely need to start doing a more aggressive testing protocol. But all those questions then come after that initial set of testing.
What do you say to people who say, but why are we doing these tests in somebody who has really no symptoms at all? Like, I mean,
Yeah, because
there's
cancer always says, hey, let me give you symptoms before I start giving you cancer, right?
right.
Like,
But
well,
none of these tests predict cancer, like the VO2 max doesn't predict cancer.
right, but it predicts how long you're going to live, right? Like if I told you this is the most important thing to tell you how long you're going to live, then wouldn't you want to know where that is and try to affect it in a positive manner, right? Sticking your head in the sand and not knowing the data isn't useful. Knowing the data and trying to apply it. Sometimes you might get too much data and you say, okay, maybe that doesn't relate to
Mm.
me, but it doesn't hurt to have it. The stuff that I get in that core thing is absolutely necessary for everybody. There's no reason you shouldn't know your VO2 max.
So there is a data out there that VO2 max directly correlates with overall survival.
Oh my God, like so much data. And it's
Okay.
so much data that it's like indisputable, right? It's not like small like causal studies. It's yeah, I wish I'd had some of those numbers for
So
you
what's
now.
what's the typical person that comes to you? Is it more of somebody who is a patient or like a healthy person who is health conscious? Like just give me a phenotype of a typical person that comes to see you and how many like do people just get to know about you and call you or is it like how does it actually work? Like because you don't have a clinic, so it's really more of or maybe you have a clinic and I just don't know.
Yeah. So actually that's it's funny you bring that up. I'm in the midst of building a clinic. It's in Oak Brook, so that should be coming in the next 3 to 4 months.
It's too far.
Yeah. Don't worry. We'll go to the North Shore next.
Okay,
Uh,
good.
But yeah, so the way that it works is, most patients come through me from referral, but I have everybody, right? Like I have an executive who's 300 pounds, who's worth lots and lots of money. And I'm yelling at him like, dude, you can't walk up 2 flights of stairs. What are you gonna do with all this cash in your bank, right? And then I have another patient who's running an Ironman. And so the archetype of my patients varies wildly. And so it really goes down to, where are you and what do you want to do? Because like I said earlier, there
Okay.
is no upper limit to what you could do with your health, right?
Right.
And so we just find them and help them from where they're at.
So now you saw this person, whoever that is, and you collected that data, you did the test and so on. What you told me earlier, then you actually are able to monitor this information longitudinally. How do you do that?
Yep. So, I mean, I think, the idea is, well, we then have our own systems for like data management pipelines where we gets uploaded to our servers and then we house them obviously in HIPAA compliant, everything. But, it's just sitting there, right? Because we're building our own electronic medical record because the EMR is out there. I don't need, Citrix or Epic or any of those things. I'm not worried about billing and all these other things that come with this, right? I have my own data management pipelines that I need to do. And so those go against my own proprietary stuff. And then it gives me my own personalized reports and dashboards about my patients. But like, let's say you came to see me, then the next things we would do be like, all right, how are you exercising? Like, well, I go to the gym for like 20 minutes and I'm like, no, that's not going to work. Here's your new exercise plan. And then it's like, okay, here's your zone 2 training plan. Here's your food plan. Like now I want your sleep data for the next 2 weeks. And it's like, okay, your sleep's garbage. We're changing the time that you go to sleep. We're going to change the time that you wake up. We're going to start trying to do some magnesium, L-theanine, apigenin. We're going to see if your HRV moves. We're going to see this. Okay, that supplement stack didn't do anything to the metrics that we're monitoring. And it's like, oh, well, where's all the data on those metrics? I'm like, I don't know. I got anecdotal evidence on 15 people that this worked. And so I don't think anybody's going to be running a $50 million trial to figure out if this is going to be a double-blinded thing to work. But it's like, this is how we do it, right? Because for us, it's cause and effect with an N of one. And it's like, as long as I have the ability to monitor you and every intervention, we're controlling for as many confounding variables as we can, then it becomes meaningful to you. And that's really the key is because we've been trained on this population health model of like, like all these large data sets and like they should be evenly distributed on either side with everybody. And that's great. And that's really helpful in certain settings. But for a lot of these things that we're working on, right, if they're more daily habitual type things, then we can monitor them and really just adjust them because we have these dashboards that pull in all these stuff on a daily basis.
But like do I wear something? Like I'm just trying to think like, do I just self-report to you what I did or do I wear something and you are able to track my sleep, for example, and my steps and things like that?
Yeah, so a lot of it does come down to wearable technologies. So it's, either like I have the Garmin watch on, you could do the Aura Ring, the Whoop Band, the Apple Watch Ultra. Like all of these things have different abilities to capture certain levels of data. all of them do an okay job at best, right? Like there is no one thing that does it well,
Right.
because and then you always have to take all the data you get with a massive grain of salt and say, okay, like, what are we looking at? Like this can't be the be all end all. We look at the general trends, we look at how these things are evolving, but I'm telling you, there's nothing, a lot of medicine is just behavioral change, right? Like everybody knows the right thing to do, but we constantly make the wrong decision. But as soon as you have a wearable, everybody, every time I put a continuous glucose monitor on my patients, everyone's diets get so much better because the thing's going off like, yo, you shouldn't have ate that. You're like, oh my God, it really is that high. Oh God, that's not good. And so yes, it's a mix of wearable technologies and a little bit of self-reporting if, we don't have the ability to kind of connect with it directly.
Yeah, I mean, but how do you change behavior? Like, I mean, I think there are certain elements. I guess there are certain things in each one's life that are just a bit out of control. Let's take the example of the executive you mentioned to me. I don't know the guy, but I'm pretty sure his schedule is pretty busy. And I understand that you should always try to make time and so on, but it's almost like trade-offs. So, in a busy schedule, in a busy calendar, how are you able to work with the patients and the people that you are taking care of to find that window where they can really focus on their health more?
Yeah, I mean, I think that is it, right? Like everything is about the behavioral change and having that conversation with patients and having the ability to talk to them about this, right? Because I fell on and off the proverbial wagon 1,000 times.
I was
And it
going
was
to say, do you practice what you preach?
yeah, I mean, I didn't, but then I do now. So but it was that transition, right? Like what in my really thick skull got me to flip? And it was like, okay, so if I give myself a task, like two major tasks this week, and I stick to it, and then I build the momentum and I develop, so much of what we do is like that kind of psychological training to be like, look, I make everybody read James Clear Atomic Habits, right? I have like little like
Great
that.
book. Great
I
book.
tell everybody like you are going to have to invest time and energy into this. Imagine if I was your golf coach and you go out to the the country club and you play like crap, you're gonna make me look bad. So like I don't want you as my patient. Like I need you to invest in this. My programs aren't cheap because when you invest financially, then you're gonna want to do the work. And so this is why even sometimes in the beginnings of my patients' time with me, I'm calling them every week. I'm texting them like, "Hey, how did today go?" And it's that oversight that's really necessary, right? And then we try to implement a lot of the methodologies that James Clear had talked about in his book with habit stacking and et cetera. But it really does come down to just talking to them and making them realize that it's all BS when anyone says they don't have time. Because, the ultimate thing is it's like how much of your wealth and money would you give back for health, right? The old adage is, a healthy man has 1,000 wishes, a sick man has but one, right? Like you'd pay whatever millions of dollars you had to not be sick, but like let's just get ahead of that. And so, it's the goal starts small. I'm like, that guy that was really not healthy, I'm like, you just have to get to 7,000 steps a day, right? And then now he's doing 13,000 steps a day and he's down 80 pounds and he's doing great.
Right.
But like from where we started to where we are, it was a lot of hand holding and a lot of calls and a lot of reinforcing and a lot of slip ups. But it just,
You
it's
mentioned
that
something
effort.
about the program not cheap. So none of your service covered by insurance?
No, you
And
can't
how
play.
does it work? Like, does it work is like it's out of pocket, like an annual membership type of thing? Like, how does it actually work?
Yep, exactly. So it's basically two tiers of annual membership fees, ranging from like $7,000 to $15,000, depending on the level of testing and oversight that you want, right? Because most of that, like the $7,000 is basically just my professional services fees, and then everything above that is kind of paid out of pocket. But that's really for my time, right? Because I keep my client base very tiny. And so because of that, I have a lot of time to discuss with you. You want an hour? Let's talk about this, right? A patient was thinking about going on testosterone therapy and putting a hyperbaric chamber in their house. So that was an hour-long conversation about those two things. Because I really wanted them to understand all of the pros and cons of testosterone therapy and all, but that's the idea is that these tracks and these investments give you the ability to sit there and really have somebody who's taking the time to go into all this.
But what do you say to people? Well, two things. First of all, what do you say to people who say that some of the things that you are doing or recommending are not evidence-based? In other words, there are no studies or things of that nature that really suggest or support that this is really going to add anything in terms of outcome. That's number one. And number two, um, um, the what do you do with situations when you get asked a question that you just don't know? I mean, you can't really know everything. I mean, I don't know everything about even oncology. So, like, I mean, somebody wants to do like a hyper, like, do you just research? Do you call a colleague? Like, because I presume in concierge medicine, you could ask all kind of questions, and there's no way you're going to know the answers to everything.
Yeah, no, absolutely. Well, to answer your second part quickly, it's like I definitely don't know everything, and I always rely on other people in the field, right? I'm actually part of this group called Longevity Docs that, it's like an international group of physicians where, the guy that I asked hyperbaric for, I paid for his consultative services to come down and teach me everything, right? Like, and so anybody I don't know, I lean on, right? But a lot of this is we go through together, and to your point, there is not evidence-based medicine for everything. One, defining evidence-based medicine is a whole different ordeal, right? If we're only talking about the upper echelon of data that we will say is the highest graded data of, double-blind randomized controlled data versus, retrospective analyses. But, okay, what are the things that I do that would sound controversial? Okay, well, you probably know about these things. Like, let's just take the Grail blood biopsy, right? Methylation changes in DNA for circulating free tumor, or Prenuvo full body MRI scans, right? Both of those things are littered with controversy because of how they've came to be. How many cancers do we catch if we followed evidence-based guidelines? We catch 3 out of 10 cancers. The other 7 out of 10 were like, oh, man, that sucks. You got cancer. Too bad, right? Like there isn't another outlet. But I'm not saying that when you do the things that I do, that I'm going to do anything. I'm saying, look, these are the tools we have. This test that costs $1,000, this blood biopsy, it could be wrong. It could say you have cancer and you don't. It could say you don't have cancer and you do have cancer. Or it could say, hey, I don't know, we have circulating free tumor DNA and it looks like it's coming from the upper GI tract somewhere. Maybe it behooves you to get an upper endoscopy. And then you get an upper endoscopy and you find a stage 1 cancer, right? I don't know, but I'm just telling you that this thing exists. My job is to say, there are tools. Here's all the limitations of the tools. Here's how it could apply to you and why it might be more beneficial given your history. Whether you want to proceed with that or not, I'm not out here selling these things. But I do want the ability to say, I've looked into this, I understand how they work. And if we put a confluence of these things together, maybe we catch 6 out of 10 or 7 out of 10 cancers. And it's not without its own drawbacks, right? What if you get a full body MRI, they see something on your lung, you do a lung biopsy, you get a pneumothorax, and then you find out it was calcium, right? Like that's not an unreasonable thing to occur. But all of these things are weighted against the other end, which is you could have a horrible thing like cancer develop and you would never know.
Yeah, I mean, it's as you mentioned, it's probably beyond the scope of this podcast to go over liquid biopsies and so on, especially the gray liquid biopsy, which I've covered in prior podcasts. And there are lots of, like you mentioned, and I'm glad you mentioned that there are a lot of very controversial issues pertaining to the outcome and the output, the sensitivity and specificity of the liquid biopsy. And I get asked that a lot, obviously, just by virtue of my specialty. But yeah, I mean, ultimately, like you said, you have to really reach what we call shared decision making, you and the individual in front of you. Um, what type of, how often do these tests need to be done? Like, I mean, let's not argue, obviously, the need or not the need and the evidence base, but if you do a VO2 max, like you mentioned, and the DEXA scan, are these need to be repeated annually, in your opinion, twice a year? Like, how does that work?
Yeah, that's a great question. And I think a lot of it comes down to, what is our goal, right? If you're already a very highly trained individual and you have a low body fat percentage count, your bone mineral density is great. And the only thing that we're doing is like, okay, you're prepping for this triathlon and we want to increase lean muscle mass. So you're on a muscle hypertrophy based program. Well, if the program lasts 6 months, then the best time to check it would be after 6 months and see, did you get that increase in your lean muscle mass that we were looking for, right? A lot of these things are dependent on the goal that we're trying to achieve. If you have lots of visceral fat and we did your initial scan, well, guess what? You probably aren't going to lose a meaningful amount in 3 months. Let's just wait 9 to 12 months before we repeat it. Another question that constantly gets asked is a DEXA scan uses X-ray. So like, how much radiation exposure are you going to put these people through? It's like, aren't there better ways? Well, the amount of millisieverts of radiation that you get with a DEXA scan is that of a flight from New York to LA, right? Like that's the amount of
Yeah, of
exposure.
course.
So it's very low. But for me, most of my patients will get DEXA scans 2 to 3 times a year, a VO2 max once, maybe twice a year, resting metabolic rate once a year, lab test 2 to 4 times a year, depending on the type of medication or if they're being hormonally treated or not. But it's kind of, it's like I'm not trying to get stuff like every month or like there's some crazy schedule that we have to follow, but it's definitely not once a year. It's definitely 2 to 3 times a year for blood work at least. And then the other tests are dictated by kind of how your improvement states along the other things that we're trying to improve.
Um, and generally speaking, you mentioned, I think earlier before we go on the air, that there are some patients you travel with them internationally if they need to get tests elsewhere. Is this part of the quote unquote concierge medicine type of thing that you actually do, or is it um, selective? Like, how does that actually work? Like, let's say
Yeah,
yeah,
yeah, I mean, so if they're my patient and they're like, I need like orthobiologics or my hip, I have a horrible labral tear and I don't want to do any type of surgical intervention, what kind of non-op therapies do we have? I'm like, well, there's certain regulations in the US that limit our ability to do, these types of therapies. So there are practitioners in other areas. And so if the patient's like, yeah, I want you to fly with me to come here, I'm not going to say no. And because they're paying a decent amount of money for me to be there. But, the idea is those are kind of one-off cases. I do, but, I give them those insights. Like there are people that exist. And these are people that I have talked to, that I've met, that, they've sent their patients to, and they have a long list of, a long history of positive results coming from this clinic. Because that's the biggest thing is like we're vetting all these people from outside sources and making sure that we send them to places that we trust is huge.
yeah. Take me through your diet. What type of food do you eat?
Yeah, I mean, like for me, my biggest thing is because I'm trying to lose a little bit more visceral fat, my goal is, it's a very protein heavy laden diet with minimal fats and carbs, right? Everyone can argue about the nuance of this. It's like, well, doc, I got this protein and I got that protein. I'm like, the best protein? The one that you actually consume. And then we could worry about where it's coming from, right? Everybody's worried about the leaf in the forest. No one takes a step back and says, okay, let's just look at your macros, man. Like you eat way too many calories. Let's cut that down. So diets are kind of specific to whatever, the patients are eating. But for me, it's like I just can't eat too much bread and Portillos and fries. I got to eat more of just the burger patty.
I know. I love Portillo's. I love the fries. You're not gonna win that argument with me.
Yeah.
I'm gonna do a study showing. I wish I could sleep better though. I think you. It's interesting. Your approach is very interesting. I think that a lot of folks will be uncomfortable because there's no evidence of that this is helping ultimately. But we can
Well, I
make
mean,
the argument.
I would totally argue with that. What are
No,
you
but
telling?
we can make an argument that there are many things we do without evidence. I'm
Well,
gonna,
not even that, but like what are you saying that there's no evidence that eating right, sleeping better, and
no,
exercise.
that absolutely. I don't need evidence for that. This
So
is
then, but
perfect.
then,
Yeah,
okay, so that is 80% of my practice,
yeah,
right? Because that's the
yeah.
hard part. Now, there is definitely evidence that taking a CCTA and then applying an
Right,
AI layer
right,
above that is going to
right.
lead to way better outcomes. But the reason that we don't do that is because that costs $1,500 and there's 400 million people in this country to adjudicate care for, right? So everything that I do use, I'm not out here like the chiropractors and the nurse practitioners trying to
Right.
sell NAD plus because I can make a $600 margin on it, right? Like that I don't agree with. Now, do I get asked things about peptides like BPC 157 and TB 500 and all that? Yes. Will I put a patient on testosterone therapy? Absolutely, right? But are you telling me that like so those things about the evidence-based pushbacks? Like I'll happily say Grail isn't a perfect product, right? Full body MRIs have a whole bunch of things that are wrong with them. But look, my patient the other day got a full body MRI. I'm like, look, the beginnings of like non-alcoholic fatty liver disease are starting to be seen around your liver, man. This is a big deal. Like, you do not want to have to be dealing with this. It scared the crap out of him. So, okay, there was no evidence that this
Right,
thing
right,
did
right. No, no.
anything.
I
But like
actually
all
was
these
gonna.
things, like, you
Yeah,
know what I mean? I get it. Like
I
everybody
was
argues
going to
with
tell
this.
you. I mean, there are many things we do in medicine that are without evidence, and we just do them because we like. I don't need an evidence to say that good night's sleep is very healthy
Yeah,
or
right.
none of these. I think where people could struggle with is when you are doing specific tests. Like you already mentioned those, right? Like when you do a whole body MRI, sometimes you could detect something,
Oh
but
yeah.
the reality is the majority of the time you don't see anything, and you don't really, you could have incidental findings you don't know what to do with. And the other thing is you don't know how often to repeat and things of that nature. So
I
I
mean,
appreciate
you're
the
an
fact that
oncologist, dude. Why wouldn't you do it? Would you
yeah,
do a
no,
full body MRI?
no, I wouldn't,
Why?
because I'm not really sure what to do with the information. I think
There you
it's like almost doing when people do PSA testing on everybody. It's the PSA testing is sometimes good, but a lot of times it's not sensitive or
go.
specific.
But to me, like the crazy thing is the argument is like, yeah, I might get useless data. Or you might catch cancer. Like it's like the cost benefit ratio of this is like you might lose a little bit of time, money, and annoyance.
But
Or
that's
you
but
might
but
catch
but there's an assumption here, right? There's an assumption that by doing whole body MRI you are going to catch cancer, and I think that's a big stretch.
okay, well, I mean, I agree. And I think like
Now, having said that, if you depends on the population, like that's where
right,
I'm thinking.
yeah.
Like if I'm a 35-year-old man walking in the door doing whole body MRI means nothing. And you're
Yeah.
probably gonna find something that is gonna be, I don't know what to do with. It's very different, for example, if you are an older person with high risk family history and things like that's where we have to tailor things. And what I'm hearing from you that you do that. You do tailor things to the patient needs. You don't do this blindly.
Right, exactly. And I mean, that's my whole point, right? Like, I'm not going to put 30-year-olds through this all the time. I mean, there are a couple that, like, some tech guys that exited their company at like 32 that have like oodles of money that are getting scanned every year. But I'm like, dude, if you want to do it, do it. But like, if you're above 45 with a first degree relative with something, or if you're above the age of 50, I'm like, okay, now you can start screening every year if you'd like. Now, again, like you said, these are just people with money and resources. They're like, yeah, I'll go sit in an MRI
Sure.
machine an hour and a
Sure.
half. And it's like I don't know what to do with this thing. It's like I don't know what to do with it either, but we'll just make sure it doesn't get bigger in a year. Okay.
Yeah.
Like again, we have to be judicious about the way we move forward, but and also not get too excited about, incidental findings.
Well, it's good to see you. This is really fun, and getting to know what you're doing is really very helpful. I would love for folks who are listening and watching this show to share their ideas, their opinions, and what they think of what they just heard. And uh, also, hopefully, you can share that with with the people that you know and get some feedback. I always think that listening to hearing feedback from viewers and listeners help us understand. And allow you to answer some questions they may have because some people are very vocal, and I think answering them and addressing the concerns is very important.
Yeah, absolutely. Thank you so much for having me on. It's a pleasure and it's great speaking with you again,
Anything
man.
I forgot to ask you, by the way, Anand, before I let you go, that you'd like to leave listeners with?
No, I mean, feel free to check us out. We're at www.lv8.health.
What does LV stand for?
No, it's just elevate. I was trying to be cute. It's LV8 is supposed to be elevate.
Oh, that is pretty cute.
Yeah, see.
That's like
You get to get
that's
lost on people every now and
oh
then.
God, way too cute for my show.
Yeah.
That's probably for the view.
Yeah, exactly. We'll see if I get on there. I don't
Dr.
know.
Anand Patel, thank you so much for coming on.
Thank you. Great talking to you, man.